Hello, everyone. It's Eric from Strong Medicine. I know I've been gone for a long time, and I apologize to people wondering where I went. Some life stuff came up that derailed making videos, but I'm back now, and for real this time. Not all of that life stuff was terrible. If you'd like to see a non-medical project that I had been spending time on, there's a link in the video description. But in this video, today, I'm going to discuss my job as a hospitalist. This discussion is going to answer 4 questions. What does a hospitalist do? How does one become a hospitalist? What are some common myths about hospitalists? And what are some of the pros and cons of the career? To clarify before starting, I'll be focusing on being an adult hospitalist in the United States, though pediatric hospitalists in this country have jobs and training that are similar. So to start off, what is a hospitalist? In the most general sense, a hospitalist is a physician who specializes in the care of the hospitalized patient. All adult hospitalists are, to some degree, the primary attending of record on patients admitted to the internal medicine service of a hospital. This means that for those patients, every day, the hospitalist sees and examines them, orders and interprets relevant diagnostic tests, prescribes medications, requests and interfaces with surgical and subspecialty consultants, communicates with nurses and other healthcare professionals such as physical, occupational, and respiratory therapists, work with social workers and case managers to plan safe and appropriate discharges, complete documentation, update families, and once the patient is discharged, communicate a summary of the hospitalization to the patient's primary care provider. Some hospitals have closed ICUs in which patients who are transferred by the hospitalist to an ICU will no longer be under the hospitalist's care, while other hospitals have open ICUs in which the hospitalist is in charge of the patient's care, irrespective of whether the patient is in an ICU or not. At any one time, a hospitalist is typically responsible for 10 to 15 patients on average. My personal lowest patient census was 1, and my highest was about 24. Now, this might seem really busy and exhausting, and it is. There's no way that a person of reasonable stamina can do that job with the same regularity as a normal job. So most hospitalists have schedules in which they work 1 or 2 weeks at a time, spanning weekends and holidays, followed by 1 or more weeks off of clinical duties. Up until now, this has been the minimal job description of a hospitalist. All hospitalists do that stuff. But there are many other potential duties that could be layered on top of this. Additional patient care duties could include providing medical consultation to surgical and psychiatric patients, staffing an urgent care or discharge clinic, or working with anesthesiologists to provide pre-surgical evaluation. Hospitalists are frequently tapped to join hospital committees and have been the biggest contributors to the emerging field of quality improvement. A relatively small number conduct clinical research. And as a consequence of their more general expertise and more flexible schedule, at academic centers, hospitalists contribute a disproportionately large share to student and resident education. I'm not saying that's good or bad, it's just the way it is. How much of an individual hospitalist's job is taken up by these various duties is incredibly diverse and depends upon both the hospital and the individual. For example, in my first job out of residency, I worked as a hospitalist in a small private non-academic secondary care center. My job was about 90% inpatient medicine, in which I served as the attending of record, and about 10% medical consultation. I had no administrative duties, no research duties, and there were no trainees to teach. Now, I split my time evenly between clinical care at the Palo Alto VA Hospital, which includes some informal teaching of students and residents, and more formal teaching at Stanford, which is focused almost solely on pre-clerkship students. I have a few MN duties, but no research, and my QI responsibilities are confined to just participating in other people's projects. This is a balance that I like, but it took 10 years to get here. When I started at the VA, I was 100% clinical, including some outpatient medicine. And over time, I looked for opportunities to move out of the clinics and have my inpatient time bought out by the medical school for education. However, other hospitalists, they might feel differently. I have colleagues in our group whose non-clinical time is primarily QI and do very little formal education, while other colleagues have their own primary care patient panel. So The next question, how does one become a hospitalist? The majority of adult hospitalists have completed a 3-year residency in internal medicine, though there is a very small number who've trained in family medicine. When I came out of residency in 2006, that was the only formal training that was needed for any hospitalist position. But things were different then. There was a significant supply-demand mismatch. Hospitalist medicine was relatively new, and hospitals were eager to hire. My wife and I each interviewed at one community hospital and were offered a job on the spot, not because we were the world's most amazing candidates, but because this hospital was desperate. Today, that doesn't happen. Many more graduating residents are pursuing careers as hospitalists, and so hospitals, particularly academic hospitals, can afford to be much more selective. What this means is that future hospitalists now often consider additional training. This might mean an extra year as a chief resident, or a 1-year general internal medicine fellowship. The focus and components of such fellowships are not standardized across the country and may be tailored for the specific individual, but usually include training in medical education and quality improvement. Some newer hospitalists have alternatively completed fellowships in geriatrics or palliative medicine with the hope of being able to incorporate those skills into their future careers. Now, to be clear, I am not saying that anyone who is interested in becoming a hospitalist needs to do any extra training after residency. Any extra training is still optional, at least for now and the near future. But it will make your job application more competitive, particularly if you'll be looking at academic hospitals. So question 3, what are some common myths about hospitalists? There's 2 big ones. First, that we act as a glorified triage nurse. That the hospitalist simply admits the patient, does all the so-called scut and paperwork, and outsources all of the interesting decisions to subspecialty consultants. Depending on where one works and one's personal style, this is either a tiny bit true or not true at all. For example, some inpatient medicine services are set up such that once a subspecialty consult has been placed, that consultant takes over completely the management of the problem for which their assistance was requested. Or sometimes they take over management of the entire relevant organ system. So if a hospitalist needed to get some advice about heart failure management and called a cardiologist to assist, that cardiologist would start ordering the diuretic doses and titrating blood pressure meds, and maybe deciding on which anticoagulant to use for the patient's AFib, all without necessarily discussing it directly with the hospitalist who consulted them. This is more typical in private non-teaching hospitals. However, it's much better for the hospitalist to serve as a coordinator of care, or else multiple consultants could give conflicting information to the patient or order conflicting medications or tests. You need someone to pull together the various opinions of organ-specific specialists and synthesize them into a single coherent plan. And this is the model of hospital medicine that is done at most, if not all, academic hospitals. But even at hospitals where consultants write their own orders, many patients don't have any consultants on their case. For routine admissions like community-acquired pneumonia, syncope, diabetic ketoacidosis, any hospitalist should feel completely able to handle those conditions on their own, which is why even in hospitals where the myth of the hospitalist as a triage nurse has some truth, it is only true a little. The second common myth about hospitalists is that the care they provide is inferior to the care that would be provided by the patient's own primary care doctor coming into the hospital. This topic stirs up some emotions on all sides. So let me go through the pros and cons of hospitalists versus primary care physicians, because it's not a straightforward issue. First, what are the reasons that argue a patient's primary care doctor might give them better care in the hospital? Obviously, the doctor and the patient already know each other, so there's already rapport and trust that's been developed. The primary care doctor also already knows a lot about the patient's medical history, so won't need to re-ask about it. The PMD is usually at least a little familiar with a patient's home situation, and so can better gauge whether a discharge directly home or a discharge to a skilled nursing facility is more appropriate. And the PMD knows how a patient subjectively looks at baseline. For example, there are some patients who always look sick all of the time, or who have a habit of always conveying symptoms with particularly scary language. And there are other patients who hate hospitals, minimize symptoms, and downplay their illnesses. A PMD who already knows if their patient falls into either of those categories can better estimate the seriousness of a new illness or new symptom when it develops. These are the main reasons that PMDs put forth to explain why they provide better care, and the reasons are all true. So, what argues in favor of hospitalists? First, since hospitalists spend all or almost all of their clinical time in the hospital, they're more familiar with the logistics of how to get stuff done. For example, if I need an unusually nuanced review of a chest CT, I know which radiologist to talk to about it. And if my patient needs to be seen by physical therapy today in order to get transferred to rehab by tomorrow, I know who to talk to in order to make it happen. Most PMDs come into the hospital just once in a while. They won't know those types of things. The second argument in favor of hospitalists is that hospitals know more acute medicine. Managing strokes, COPD exacerbations, and renal failure, those are the kinds of things that we do every day, so we get good at it. If you were a patient and admitted to the hospital with a heart attack, would you rather be cared for by your PMD, who knows you really well, but may treat heart attacks a handful of times a year, or by a hospitalist who just met you, but who treats heart attacks every week? This is just like how a patient should not trust me as a hospitalist to accurately diagnose chronic musculoskeletal or gynecologic conditions. Those would not be within my area of expertise or typical scope of practice. When it comes to providing prognosis in a patient with severe and or terminal illness, it is my strong personal experience that the better the doctor knows the patient, the less accurate their prognosis is. Meaning, if a patient has metastatic cancer, a PMD is more likely to tell the patient they have 6 months to live when 3 months might be more realistic. It's an unconscious error in judgment caused by bias due to their pre-existing long-standing relationship. And finally, and most practically, the hospitalist is physically in the hospital all day. If a patient already in the hospital develops worsening shortness of breath or an allergic reaction to a new medication, the hospitalist can just walk down the hall and assess the patient in a matter of minutes. If your PMD is the inpatient doc, they could be across town in the middle of clinic and not available for hours. This problem is also true when family members come to visit and want updates from the doctor. Hospitalists can usually walk over and provide a face-to-face update right away, whereas a PMD will usually call the family on the phone later in the day, if they even receive the message at all. I've been on the family side of this problem, and it was profoundly frustrating to not be able to speak to my relative's doctor in a timely manner. So, as you can probably tell, I believe that there is, as a very general rule, hospitalists provide better inpatient care than primary care doctors, but it does have debatable points on both sides, and it's not as clear-cut as some people make it seem. And the last question, what are the pros and cons of being a hospitalist? In other words, how do I personally like it? I need to be honest here. I don't love every single day. When I am on service, the hours can be long and the job can be exhausting. Hospitalists are asked to take on responsibilities that no one else wants. And in contrast to fields like surgery, most of the patients that we take care of either get better or get worse, irrespective of what we do. In other words, I believe that my presence, knowledge, and skill only makes a significant difference in a minority of my patients. This can be disheartening, but it is the nature of the job. However, after more than a decade, I don't regret the decision to become a hospitalist. There are certainly other fields I considered along the way, but in the end, I'm happy with the choice that I made. It gives me an incredibly broad exposure to pathophysiology and keeps up my medical knowledge. For me, it's also a good balance between treating some of the acute, exciting stuff while still having an opportunity to develop personal relationships with patients. Being a hospitalist has also been wonderful for my interest in medical education and has allowed me to take a much larger role at the medical school than I probably could have in a different specialty. Since some viewers will inevitably wonder about compensation, I'll say that the compensation for hospitalists is about average for a doctor when adjusted for our relatively short length of formal training and average job competitiveness. So that's my job as a hospitalist. I hope I addressed the things you've been wondering about. If you have additional questions, please feel free to leave it as a comment below where I will try to answer them all.